אוקיי, אנחנו מתחילים. Okay. Hello, everybody. Can you just chat if you can hear me?
We hear you.
Okay. So right now we have like 10 participation. We will wait a little bit because we're supposed to have more people. I just want to make sure that Dorit, are you there? Dorit, I don't know if you are there. Can you confirm?
She says, yes, I am.
Okay. Okay, Dorit, can you switch the video or not?
She says it's open.
Okay, I still cannot see you. Okay, I suggest that we will wait like 2-3 minutes because there are more participation who should join us, and so let's wait a little bit longer because I know that some other should join us. Anyway, for those who will not be participating this evening, we will have the record, of course. Okay, Eivind, we will start, I think.
Yes.
And we will, and people will join later on. So good evening for everybody, for those who are participating for our first webinar in Israel. I just want to make a short brief how this evening is going to look like. So Dorit Greenberg, who is our distributor in Israel, the CEO of MDS Farm, will speak shortly in Hebrew to the Israeli practitioners. Then I will make a short introduction in Hebrew as well, because I'm an Israeli, to the Israeli practitioners about our company, what we are doing. Then Eivind, our guest speaker today, will take the lead and will introduce us a very interesting clinical case of heel pain. You will have 10-15 minutes for questions, of course, by the end, and then we will close this meeting. So this short brief about how this evening is going to look like. Dorit, do you want to switch to Hebrew and saying a few words?
She's typing. Yes, but you can't hear me. So we can't hear Dorit. She would love to say something.
I'm trying to understand why.
I think it's something with the hosting. She has to be a host. for those.
Let me see.
Those who created the event. You're the admin, so maybe you can, on the 3 digits on the side, maybe you can make her a host. That looks better.
Okay, Dorit.
Now we see her.
Okay, technical issue solved, but we cannot hear you. Dorit, you might be on mute.
Is that okay? You can hear?
Yes.
Good.
Okay, so let's start now from the beginning. קודם כל, תודה שהצטרפתם לוובינר של חברת פודוסמארט. אנחנו ב-MDS Farm שמחים לייצג את פודוסמארט בישראל. אנחנו מאמינים ששימוש בטכנולוגיות אבחוניות כחלק מתהליך השיקום יכול להיות כלי יעיל וחשוב להצלחת הטיפול הפיזיותרפי. אנחנו מאמינים גם ששילוב של דיאגנוסטיקה לאורך הטיפול עם מגוון המכשירים הטיפוליים שלנו יכול להוות בסיס לטיפול המהווה פריצת דרך בתחום השיקום. היום אנחנו הולכים לראות את זה. אני שמחה מאוד שאתם איתי ומעבירה חזרה את השרביט לאוסטר, הנציג הישראלי בחברה, שגם יציג את החברה וגם את הדובר שלנו לערב. אני מאחלת לכולנו שיהיה ערב מענה ופורה.
תודה רבה. Eivind, so just if you can introduce, please show the presentation.
Yeah.
If you want to share the presentation.
Yeah, I can share.
Okay. So for the English speakers, I will make a short introduction in Hebrew about the company. Go to the next slide, please. טוב, אז קודם כל ערב טוב לישראלים שבחבורה. אני רוצה להגיד שאני מאוד שמח, וובינר ראשון לשוק הישראלי בעברית, פעם ראשונה שאני עושה את זה בעברית. אז למעשה, מי אנחנו? אנחנו חברה צרפתית, אנחנו קיימים למעשה החל מ-2015, אנחנו נמצאים בעיר שנקראת ננסי. כיום החברה למעשה מתמחת בייצור סוליות חכמות למגזרים שונים. ב-2019 זאת הייתה החדירה הראשונה שלנו למעשה לשוק הבריאות, לשוק ה-healthcare. והמוצר פודוסמארט, המוצר שהשקנו אותו ב-2019, למעשה היום נמצא ב-20 מדינות, מעל 20 מדינות, רק באירופה יש לנו משהו כמו 700 משתמשים, שזה בהחלט מכובד בפרק זמן כל כך קצר של שנתיים. אז למעשה המוצר מכוון בעיקר למטפלים, פיזיותרפיסטים, פודולוגים, גם דוקטורים מתחום הנורולוגיה, כל מי שבעצם מתעסק בתחום של gait analysis. Eivind, can you switch please to the next? Thank you. אז למעשה, פודוסמארט, למה זה מיועד? חילקנו את זה בעצם לשני חלקים. אז קודם כל לעזור באמת לפיזיותרפיסטים, לפודולוגים, להשאיר את הדיאגנוזה, את ההבחנה שלהם, ובעיקר לפיזיותרפיסטים לעשות פולו-אפ, למעשה כשיש תהליך של שיקום, אם זה אחרי פציעות, אם זה בעקבות גורמים שונים, וכמובן אני יכול להעיד שהמערכת למעשה עוזרת מאוד להאיץ את תהליך ההחלמה. והקבוצה השנייה אפשר להגיד שם אנחנו עוזרים באמת לאנשים ללכת טוב יותר, לשפר את הביצועים, להוריד את רמת העייפות ואפילו למנוע פציעות. You can switch to the next one. אוקיי, ולמעשה אנחנו יכולים להגיד שאנחנו מכוונים לקבוצה די רחבה של פציינטים, לצורך העניין, כאלה שסובלים בעצם מבעיות מכניות של שריר השלד, ספורטאים אחרי פציעות שרוצים לחזור למעשה לתחום הפעילות שלהם, וכאן בעצם אנחנו עוזרים ללוות את תהליך ההחלמה, תהליך הריקאברי שלהם מפציעה כזאת או אחרת, ועוד הרבה תחומים נוספים. היום אני רוצה שנעבור בעצם לקליניקל קייס, בעצם למקרה ספציפי, שייתן לכם הבנה איך פיזיותרפיסטים יכולים להשתמש במערכת שלהם במקרה ספציפי שאייבינד יציג. Eivind, I will switch to English now because I'm going to introduce you. So just go to the next slide, please.
Yes.
Okay. So Eivind Møller from Denmark, physiotherapist since more than 20 years. This is our guest speaker today. Eivind, you are going to discuss and to introduce a clinical case supported by innovative gait analysis solution, which called heel pain.
Yes. So thank you for inviting me to take a little talk about the just the clinical case and how we in our clinic work with those issues around heel pains, but also around what kind of tools and how we manage to kind of both clinically differentiate between what the problem is and how to ease the patients the best way and to give them the best solutions to recover. So just shortly about me, I'm 50 years old. I'm a physio since 1997, so it's been quite some years now. In 2005, I became an osteopath, and just recently this year finished off a university degrees specialized in manual therapy and the effect on running performance under the Master of Science in Osteopathy. So professionally, I've been working primarily with active people since the beginning of my physiotherapy career, and also during these years. We have a private liberal clinic in Copenhagen, so we have maybe a bit of non-typical client in general, as we are private, so people are not funded at us, they pay for themselves. So therefore a lot of those people we have are in the active segment, so and that being from pure beginners to actually Olympians that we have helped prepare for the Olympics. Me myself, I've played elite handball in my younger days, and now I'm just doing recreational sports like sports and running and cycling and swimming a bit. So, and at the ending, I'm married, 4 children with a boy at 23 and 3 small girls now. So, a bit short about me. But today's topic, what we chose was the discussion of one of the most, maybe not one of the most, but a typical problem I see in the clinic, the heel pain. But before that, I was asked about why do we actually use stuff and mechanics like the gait analysis, and well, we have for several years, and that is definitely something we still have to take into account. That is, it's always the manual examination and the clinical evaluation and the broader perspective of our professional mind that has to take into account the measurements that we do. But definitely the specific tools of the gait analysis is definitely used to primarily in 2 aspects, and that one to prevent injury or to reduce any discomfort, and in sports people also optimal actually performance optimizing their situation. So that is both in regard to from a theoretical improvement in energy reabsorption and stuff like that, but also in terms of more of a reduced injury situation for athletes to in second degree, thereby enhancing their performance. So what we do is when we use the evaluation, we kind of look into, of course, the mobility, because mobility is an essential part of the functionality of the foot and the gait in itself, but of course also with stability. So what we do that is, in regard to the mobility, we quickly look into a manual examination. We look into and feel the foot. How is the foot and the lower legs and the entire leg actually working in congruence with each other? We do visual observations on videos, and we do a dynamic evaluation, both just standing and watching people doing one leg stance testing, but also using tools like the dynamic foot pressure scanner that can see how the balance is done with the patient. So summing it up, we do clinical hands-on examination and understanding what is going on in the foot and in the related structures of the body. And we do the observational part where we actually see on the video with the slow motion. For our instances, we don't use a high-tech, high-speed camera solution with fixed cameras. We just use the iPad and Huddle app, which actually can take slow motion videos down to eight times the speed. So it's really, really fine to observe and to teach the patient in non-parameters that should be addressed for them. And then we do the dynamic where with the PodoSmart that we have used in the clinic for almost now 2 years, which has helped us very, very much to see what's actually going on inside the shoe. That is one of the perspectives that we have looked for in many years, to see, well, we can look when people walk across a plate and see how the foot is working, but then they have to walk barefooted, and it is typically in a clinical setting, we can't see what's going on, and it's a bit biased according to what's going on in the real life. So here, PodoSmart has really been a help to give us some access points to see and show the patients what's going on. So who can benefit from a gait and run analysis? Well, the short question is everyone, and especially people with an active life where they use their feet. So whether it's being Eliud Kipchoge winning the Olympics in Tokyo this year, or it's been a walking person who just wants to recreational walk in the mountains, or persons who have to have specific requirements for their work situation, or people with this specifically handicapped or impairments of any sorts, orthopedically or rheumatic, or in any other impairment situations, they can all benefit from having an gait run analysis in respect for what their from what their goal is. So someone wants just to have an improved comfort, someone's again want an improved performance, and some again has a specific handicap or an impairment that they really need to solve or be closer to a solution for them, because we can do a lot of things with our clinical hands, but bringing it out and summing up any more tools to look into the situation with the patient with cameras and diagnostics tools is specifically good. So, and the next question is it actually something that matters anything? Is there an amount of people that need these situations? And I can only talk for the situation in Denmark, as I'm working in Denmark and I see a lot of patients. So from my own empirical perspective, well, there's a lot of people using it. But from a national perspective, the Danish Health Authority actually has, for the last, or in the period from 2010 to 2017, actually asked people how they were. So they had this survey called "How Are You?" And in that survey, where you can see that the blue columns is 2010, the green column is 2013, I think, and the red one is 2017. We see that the question for those columns were, do you have pain or discomfort in the extremities and joints in the last 2 weeks in Denmark? And if we look into the bottom of the corner in the map of Denmark, the green and yellow part, that's Denmark, to anyone who doesn't know it, we see that it's more or less between or around 50% of all people when we took it into an average account that has within the last 2 weeks have had pain in or discomfort in the extremities and joints. This covers for both upper and lower extremities, but it tells a lot of stories, or it tells a lot about that pain and discomfort is definitely a part of at least the Danes' everyday life. And I think that when we look into global statistics, I think we will look into some of the same patterns, that more or less a majority of us or half of us have discomfort or pain. And of course, as you can see, going more right, we have the more elderly persons, and the younger you are, the less a problem you have. And it's the same patterns whether you're man and women. So man on the left and women on the right. So specifically to this topic of the night with the heel pain, we have this case study where I took a patient in who had several problems and had several issues around heel pain specifically, and just to show that how we addressed it, and by the end also why and how we used the PodoSmart to address and investigate and give us some help on solutioning. Taking care of the problem. So this is Helen. She is 50 years old. She's working at an office. She has a regular office work. She's not very physical active, but really loves to walk. She is, the BMI, the body mass index is 25.8. She's not heavy, but she's not light either. She's very ordinary, I think. So her problem is, for when she addressed me, is that she had this, for the last couple of years, had chronic heel pain and discomfort around the left ankle region. And when we discussed about what had happened, she really couldn't address one situation that occurred that made this happen. It just came out of the blue, more or less. But during the anamnesis and the history taking, we found out that she had kind of a debut of psoriasis arthritis in her right knee, and the right knee, meaning the opposite leg than from the left heel pain, and that started 10 years ago. When we examined the foot and the ankle region of the left side, we found really no major mechanical restrictions in the left ankle, except from a bit of a dorsal reduced dorsal flexion, but really nothing that could really, from a clinical perspective, address that. This is really a mechanical issue. You're having a blocked bone, or you have too tense or too rigid foot, or something that could have explained why she had these problem with her knee heel pain. For the psoriasis arthritis in her right knee, it was she started after some times to have these biomedics. And those had really helped the psoriasis arthritis, so it wasn't active anymore. So she had a sleeping arthritis now. She didn't have really any discomfort from inflammation or stuff like that. She had a knee that had taken some beating from the arthritis, so it was not a mechanical, really strong knee and well-functioning knee, but it wasn't, again, not really bad. And just lately she had received some cortisone injections to the knee, to the left heel pain area. Through the years, both for the knee, but especially also for the last couple of years, she had visited several amount of healthcare practitioners, physios, massage therapists, acupuncturists, doctors injecting stuff in her, giving her exercises, and nothing had really helped about the situation. And it made clear for me that if we just followed the traditional way by looking into the issues around the left heel, we will probably go the same way than any other treatments or any other healthcare practitioners, because there really wasn't any mechanical restrictions in the area. So the major headline of the situation that she had no effect of any treatment yet. So I really had to bring in a bit of clinical reasoning just to figure out why had the other really excellent doctors and therapists that she had visited not had success. So we really had to look into some ideas of some other ideas, I thought. Just to bring back a bit about heel pain in public. The American College of Foot and Ankle Surgeons made a revised practice guideline in 2010, where they estimated that probably 10 to 15% of all foot-related problems are heel pains. So of these foot problems in general, heel pain accounts for about 10 to 15%. And in respect to this case that I had with Helen, actually the majority of heel pain has a mechanical etiology according to them. We of course have neurological, we have trauma, we have any other sorts of diseases that can have influences. But the major part of their observations from these part are actually that it's a mechanical issue that brings on to the occurrence of the heel pain. Going on, in regard to our profession as physio and osteo and other manual practitioners, and taking care of these situations, we have to look into a bit of what has actually been. Well, it's difficult to say proven, because I think the evidence is still very, in general, poor for specific targeting of this is the solution for treating heel pain. But in some reviews from 2017 from Italy, where actually 20 randomized controlled studies were investigated and 9 interventions were investigated. And in 2018, actually from Israel, also 6 randomized controlled studies were investigated. And in the latest one that I just recently read from 2021 from UK, where it's actually a quite big one that is giving the what we call the most recent guideline for treating heel pain. In UK, they investigated actually 51 trials of those 9 randomized controlled trials, investigating more or less about 10 interventions. And from these reviews and meta-analysis, we found that, well, the primary effect, or what we should work with, or what has seemed to be on the short term for working on heel pain, is actually stretching, taping, and education of the patient. And if this is not successful, we can also use extracorporeal shockwave therapy. We can use inlays, foot orthosis, manual therapy, laser dry needling. So what are these reviews said? That some of these treatment therapies have a bit more effect and seems to have a bit more validated effect than others, but these others also seems to have effect, but not as valid or evident as these primary effects. So, but compared to placebo, stretching and taping and education is definitely the primary aspect of treating patient. So, and one of those is specifically the education. So, and as I mentioned, 2021, the UK guys came out with this best practice guide. So, in regard to plantar heel pain management, and what they actually found out was that at the top of the core approach, and I think this is general in when we look into modern pain philosophy, is patient education, making them understand why the situation has occurred, why this might not be something that they are going to die from, or in regard make them handicapped in the longer term, that they can actually work on it. So I think from a modern point of view, education again is the key topic, or the key or the core component of us as therapists to go into the dialogue with the patient, understanding the situation of the history for the patient, also understanding the situation of the patient, but also taking into account these giving the patient these understanding of what is actually going on and what can help them from a general evident perspective, and what can be investigated into if the primary objects don't have the wanted effect. And as I say, the primary effects, or the do's that you have to do with plantar heel pain, besides education, is the plantar fascia stretching, and on the other side, taping. And if these specific evident tools are not giving the result immediately or on a short term, we should go into an individual assessment. And from the individual assessment, we can go into a much broader and wider variety of assessments, being managed load. You can talk about running techniques. We can talk about pain education. We can talk about weight reduction. We can talk what kind of shoes are we wearing. But it still definitely has to be with the individual in the core perspective. So what sometimes happens is that people just take a tool off the shelf and then just add it on to a patient without thinking about what is clinically relevant for this patient. And I think really that is the outcome of this last practice guide, best practice guide from 2021, that the core component is education. And if we want to have effect of the education of the patient and bring it on to other tools or other interventions that we want to bring on because the stretching and the taping hasn't worked, we really need to have the individual assessment, because otherwise we can't bridge between the educational objective and the effects that we want to have on the patient with the specific tools. Because if they don't understand why they need to have an inlay sole or an orthotic inlay, or if they don't understand why they have to maybe change a bit of their running pattern or lose a bit of weight to reduce the pressure to the heel, then we will lose them, and then they will go on to the next therapist. That's just my opinion, but I think also it's subsidized by literature as it is for now. So how do we work with these ideas and these mindsets in everyday life at the clinic? So we have a very down-to-earth idea of working with patients in our clinic. So we kind of take the structural and physical world and say, well, this is how it is. We can't discuss gravity. We can't discuss mechanical forces, shear forces, and how things are working in this world. So that is one of the columns or the cylinders that we just have to accept. And then we have the integrated function of the body, the integrated function of the patient that we're sitting in. How are you working? Do we have only old trauma, operations, diseases like psoriasis, arthritis that has affected your knee or anything like that? Do we have situations within you that reduces your ability or the patient's ability to actually handle the outer world, meaning the structure and physics of the outer world? So those two things are really the things that are battling together with each other. So in short, saying, well, if you have one person running 10 kilometers and another person not running not being able to run 10 kilometers, it can't be the 10 kilometer meaning the structure and physics that are the problem. It must be the problem must be within the person who can't do it. So otherwise the other person wouldn't be able to do it either. So when we take those two and working together, then we take the last column, which is one of the tricky ones to work with. It's the patient's habits and behavior in regard to how will we change habits and behavior if we need to change the integrated function in relation to working with the structure and physics in the outer world. So we kind of put these together in an individual whole-centered perspective and just bringing it onto a whole circle and saying, well, we have these issues that we can't do anything about. We have these things that are within you. How do you function, and how do you how much are you able to actually change your habits and behaviors, and put that into one big pot or one whole circle, and then from that defining, are we going to take a very structural perspective, or are we taking a more narrative perspective and telling people how to go to their goals, actually just taking into account both the physics and minds, or the psychology and the minds of the patient, but also very much the physical world and the functionality of the actual body, the biomechanics, and regard to the means and effects of the physical world. So that is how we want to work, and how we address within our colleagues and then within the clinic, and what our customers expect from us, that we have this individual whole-centered perspective in regard to that, and not just taking, again, I've been to this course, I've learned to use shockwave, every one of my patients should have this shockwave because it's really easy to use and I make a lot of money on it. That's not the way to work. We really have to keep the patient in center. So that was just a short take on heel pain and how I want to work and what the evidence says or literature says as for now in 2021. As I mentioned in the beginning, Helen was a bit of a case because she had really visited a lot of, and what I heard from her, a really good and competent therapists and doctors, and no one had success with her. But what I also heard that they really addressed with a focus on the heel. So what we really had to, in my opinion, was to think a bit different. So as we didn't find any mechanical restrictions of any major character, either in the left foot or in the right side of the body, we though found a severe difference in the motor control on the one-leg stance test. So we did just simple one-leg stance test, and was really, really clear that her right leg, which was the one that was affected the knee, really had troubles on just keeping the balance. Whereas on the left side, she had really, really fine balance as such. She was she had no problems on standing on one leg, but just standing on one leg with open eyes was a really problem for her on the right side. So there was definitely some neuromotoric issues around how to control it. Whether it was because of the knee, it probably would be, but we couldn't address that there was a specific link between that. But observational, we could really see that there was a problem in the right side on the neuromotoric control of Helen's leg. So from that, I had an idea, and I wanted to see, well, if we use the PhotoSmart and had a gait analysis of it, because what she said was that the primary problem is that she wanted to walk, and she wanted really to use her feet to actually just be able to do some recreational walking. It had a lot of impact on her life that she couldn't walk, and she hadn't been able to walk really freely for 2 years now with the heel pain. So we went to see what is actually going on inside the shoe with Helen's feet. And as you can see here, just as we did with the neuromotoric test on the one-leg stance, the same pattern on the neuromotoric control came out with almost from, it couldn't be better regarding to literature on the left side. It's almost perfectly inside the corridor of what we would call the estimated values or the mean values of how we would see a gait protocol. But as you also see on her right side, it's really not good. It's really, what we see here is that when we in the middle we see the mean of the every step that has been taken with the standard deviations on the thin gray lines, but the mean is in the darker lines with the dots. So that is the mean of all her walking or the testing period, which was of about 2 or 3 minutes, walking outside of the clinic with the soles in there. But as you see, there is a major variety, and standard deviation is quite big from the left to the or from side to side on her right side, giving her a very, very turbulent and very undefined gait pattern on the right side. And on the left side, a really beautiful and very by the book gait line. So when we saw this, and when she saw this, we really opened up her mind of, oh, this is something we should work on and should address. So we kind of concepted an idea out of these observations, both from the clinical perspective and the historical analysis from the interview of her, from all these therapists that didn't really success with it. So the idea of was that from the observation, we saw that there was this prolonged period of hurting in the right knee. And as we know from especially a Canadian guy that has Thomas Michaud, who has written a great book on biomechanical patterns. He's I don't know if he's the one who's mentioned it, but the path of least restriction is a known phenomenon. I think that the body always will find the way to ease off the pain or ease off the hinder to making a smooth walk. So when we look into that idea of the path of least restriction, we could argue that a point of a compensatory pattern has evolved from the situation with the incident or the starting incident of the psoriasis arthritis in her right leg, and that gives avoidance leading to the loss of motor control, giving you the path of least restriction. Body leans to the left leg by bringing the body weight over to that leg for I've written 24/7. So just meaning that her general pattern will be addressing more weight bearing to the left side. And as we didn't see any malfunctions in a mechanical perspective, regardless of that the American College of Foot and Ankle Surgeons says that the primary problem of heel pain typically is mechanical, we should look into this. So what we did was showing her the paradigm, showing her the investigations. We talked her through it, and also visually and deductively, we gave her the feedback from the PodoSmart. We gave her local stretching and self-mobilizing of the left foot, just to stimulate and give some feedback on it. We gave her some optimized footwear. We gave her an American shoe brand called Ultra Paradigm 5, and then gave her, on the upper side leg, strength and coordination and balance training for the right leg. It's very, very hardcore specific in trying to increase the motor control of the right leg, giving the idea that then we could bring back and give more balance to the body and the alignment of the right and left and right side, as there would be an improved motor control of the right leg. And then from a specific point of view, also just to give a general training of her, we gave her some non-specific gymnastic exercises for general motor control of both legs, of course. So not giving it too much left side this, right side this, but also just summing it up and giving a good, smooth education of her body. So from this on, that was kind of this summing up of this situation of Helen, that she was really a tricky case. She had no really clear signs of what was going on. But with the PodoSmart and the history taking, we found our ways to give a new approach. And she was happy out of the office, because that was the first time someone really actually, and that is a bit of experience to the other therapists, no one had explained, as the key perspective of the last point here was education of the patient. No one had explained her what could be the reason, what could be the issue, because they were apparently always or too much focused on the symptom and trying to relieve that. But what we did was that we gave her insight, we educated her, we gave her solution, and made it clear that she should understand why she should do the exercises, and she grasped it. And the intake of this situation, or for this evening, and regardless, and in regard to the PodoSmart, could we have worked it out without it? Yeah, probably. But did PodoSmart really help us? Definitely, because the didactical work that PodoSmart does, or the examination taking out of the PodoSmart, really helped both me, also to just address, I have something, but also for Helen to understand, oh my God, I can really see that there is a difference. So the visual impact on her in regard of educating and learning and understanding what was going on gave her a whole nother perspective on going on and going out of the door and bring home the exercises, and understanding why she should do the exercises. Because we all know that people are given exercises, and one of the major issues is that they never do the exercises. But if they understand why they should do the exercises, I think that is a good reason for us to believe that maybe the grade of or the number of people doing them might increase a bit. So that was a case of Helle, supported by PodoSmart. But in general, just my take on how to work with a clinical case like her, using my clinical brain, my experience, my understanding of where is the evidence, protocols and guidelines for modern evidence practice, and then with the best tools at hand. Thank you.
Eivind, thank you so much. It was so interesting.
Thank you. Welcome.
Thank you. Thank you so much. I think we will switch to some questions that you want to ask Eivind. So I think this is the good time, great occasion to ask different questions. Could be related to this particular clinic case, but not necessary. It could be some general questions about PodoSmart, whatever it is. So please go ahead.
Yes.
Don't be shy. This is the time to ask questions.
I think Roman has asked one, is it easy to implement in the practice when we take into account of the PodoSmart? I think that must be the whether or not. For me, it has really been easy to use it. It's really it's just straightforward. So I think in when we see in other aspects of clinical and technical guidelines or technical tools, I think this is one of the easiest tools that I have met so far in regard of both implementing, but also in regard of taking the values out. It really gives you values straight ahead, and also the idea of it's more the way you can use it as a tool also to explain the patients. It's really obvious. So some of the tools that we are using are very clinical practitioners tools. So it takes a clinical practitioner to understand the pictures and understand the numbers. What I think is so good about the PodoSmart is that it has these numbers, and you, of course, as a clinical practitioner, you understand and know some of the numbers specifically, and that doesn't make sense for the patient. But for the pictures, the way that you have shown with the person going on and showing the gait and the swing phase, or the stance phase and swing phase, and all these. The way to use pictures and describing the measurements or the results is really nice and really accessible and very easy to implement, I think. I say Ramsay's asks were the contact and swing phase times between both legs dissimilar? Not in a way. There were differences, but in a very minor way. So both visually, but also from these, I think there were no major dissimilarities or abnormalities between them. The major differences was really the gait line. There was something in the chat.
Do you have to show the participant some graphs or all the way from the beginning of the treatment till the end of the treatment, how you show your patient with the results, and what is how the advantage of using the PodoSmart technique effect on your treatment?
I think one thing is, and that is one of the things that the PodoSmart does. It actually makes it possible to compare. You can have two measurements and you compare them up to each other. It's a great thing to use. I think one of the things that I have observed through years in general, but also in with the use of PodoSmart, that when we go down to actually quantifiable measurements, we tend not to see major differences in even on a bit longer term. So people don't change the pattern dramatically by training and stuff like that. But so and usually, personally, I don't use it very much as pre-treatment, post-treatment, or pre-training, post-training period measurements. I could use it, but where I see the most valuable effect is the you could call it a wow effect, but also you just the didactical effect from the patient to see, oh my God, I can really see it. That's the point where I really can see the major impact. But of course, you can do it like, for instance, with Helen. I haven't had her for her follow-up yet. But at that point, it could be interesting to see, well, how is her situation changed? Has it changed a bit? Has it changed on her heel pain or any of those problems that we addressed? Has her neuromotor control of her right leg, has that improved? Has my battery of exercises been the right ones for her to do? So, and that still has to be in the clear, but that was so in general, I think but that accounts for me how I use it. I really use it as the first time. See, this is the difference, or this is the difference between right and left, or this is from literature. We know this. This is how your foot works. Or we can take, for instance, runners. We can say, well, when you run in this shoe, you have this medializing of your foot. When you run in this shoe, you don't have this medializing foot. If you run a bit on a single or a zero drop shoe, we can see that the amount of energy that is forced down to your foot is less than when it is on another type of shoe. So I use it personally more on a one-to-one, not as much in a test situation, but it's really compatible to do it. Yeah. Did it answer your question? Sorry.
Yes, of course. Yes. Also, I suggest that I will send them after hearing this webinar. I will send a sample of a patient that you can compare and see what is the difference, and to see all the graphs what
Yes.
you can see with this system.
Yeah, you should do that, because the picture I have shown is just one picture.
Yes, that's what I meant, because we saw only one graph, so there is a lot in this system, and every graph says something else, and everything is important. And so when they will see a sample of one patient, so they can appreciate the information that comes with the PodoSmart.
Yes. And I fully agree that there was just to take one, just a small but a very clear piece of this situation with Helle, the patient I had, where it was really, really visually clear what that was this difference. But when we look into, for instance, I had a runner last week where she had issues around the type of shoe. So she was running in a very classical Cayano, Asics Cayano, which has a big heel drop, meaning the difference from heel to forefoot. And then we put her into a zero drop shoe, which is the same height at the heel as in the forefoot. And we could see immediately we could see that the inclination angle when she was landing was diminished by 3 or 4 degrees. So, and she could feel one thing, that she could feel it, but that showing her on the measurements that, well, the measurement says it also. And then we, at the same time, we also took a video on her in slow motion where you could sense that there was this kind of change in inclination, but it was really not that clear. But when we showed her the PodoSmart measurement, it was 3.5 degrees, bang. Then there you are. So it's not about, and it's important for me, even though I really, really like PodoSmart, but it's the combination of different tools that really, really enables us to be good clinical practitioners, both using our hands, our minds at the first, but then using these great tools that we have at hand, and then we should choose those that makes best sense for us. But for me personally, I think that the PodoSmart has given me what I have looked for in many, many years, to see what is going on inside the shoe. That is really one of the big perspectives for me to have had now, because usually before I had this pressure plate where people were walking barefooted on it, but then you could see how the foot was walking, but it was outside of the shoe and it was in a clinical setting. So there was a lot of biases that could be argued to have an impact on your evaluation. So yeah.
Eivind, I want also to add something very important, that by the end of the day, using PodoSmart, it is really describe the natural way of walking, because by the end of the day, we are static. We are not static. We are dynamic when we are walking, and also we are wearing shoes. So when you are barefoot and not dynamic but static, it's not so close to a natural way of walking. Am I wrong?
No. It's, and that's, we want to have as little biases as possible and as close to a natural situation. So the perfect situation is that, could I have your shoes, and then go out of the room and just put the other soles in and say, well, come back and say, could you take out your shoes and just go for a while, and not mention anything about what was going on. That is in an evidence-based practice, of course, or in a methodological way, the best way to do it. But again, people know what's going on, and we can definitely. I think people are interested in it, and I think as much as we can, just to pull out any distractions and stuff that influences on the way of how the measurement output will come. For instance, on the pressure plate, now we are working on a pressure plate where they have to walk like 6 meters inside a room back and forth to have the measurements. This is much better. We can say, just go 1 minute up the road, come back 1 minute road, think about something else, have an ice cream almost, but just walk. Don't think about anything, just walk. And that's just summing up to, I see that there is a question from Manos Voskakis, where he says that he asks, how many recordings did you base your findings on? And that is actually one of the, you could argue that I should have more recordings, but one of the, for Helen, I only had one recording, and you could argue that that is a failure, or it's that could be some discrepancies if I took another measurement. But one of the ideas of the PodoSmart is that because you take such a long data period that you walk for 2 minutes, then it could be argued that you would have a reliable picture of how their walking pattern is. Of course, if you ask them to walk around in a circle for 2 minutes, well, you would see that the walking pattern would be influenced by the walking situation. But what we did with Helle and what I do is that we live just next up to a path, a walking path, so which is just straight out for like 500 meters. So I just asked them to set the clock and just walk 1.5 minutes down the path, and then come back 1.5 minutes later. So they have this a good volume of measurement taking into account of that one measurement. Did that make sense, Manos? Yeah, thank you. So, but again, it's a good question, because typically we want to see, for instance, when we do a one-leg stance test, you could take one-leg stance test, and if the patient really makes a good balance, and if you only do that test, you can say, he has good balance. But then if we ask him to do like 9 more and he has really shitty balance on the next 9, then we would have a false objective from him on the one test. So typically in methodical perspective, we will always have a battery of reproductions of a test. But in clinical everyday life, this is actually one of the things that the PodoSmart brings us on with that beyond, because it takes so much measurement on a prolonged time that it makes it possible to have what I would say a valid result. But of course, you can always do it twice or more.
Okay, so we are actually, it's already 1 hour. If there is no any other questions, I would like to say thank you, Eivind, for the
You're welcome. It's my pleasure, as always.
Great presentation. Dorit, do you want to finish by saying a few words in Hebrew to the Israeli practitioners?
Yes. אני הולכת לשלוח לכם את ההקלטה של הוובינר הזה, כדי שיהיה לכם, אם תרצו לראות שוב או להפיץ בין קולגות. בנוסף, מה שהיה לי חסר כאן, אמנם זה באמת מה דוח, איזה ממצאים אנחנו באמת מקבלים מהמערכת, שזה משהו שהוא מאוד חשוב, כי באמת זו מערכת מופלאה ואפשר לראות הרבה דברים, ואז אני הולך לשלוח לכם את זה, ואחר כך מי שירצה ליצור איתי קשר, להתעניין, ובמידה וזה מעניין אותו איך להשיג מערכת כזאת, איך לעבוד עם מערכת כזאת, אז אני כמובן אשמח לעזור, ואני מאחלת לכולם ערב נעים, ותודה שהייתם איתנו.
תודה רבה דורית, אני רק רוצה באמת לחדד את הנקודה הזאת, שכאן למעשה אייבינד הציג גרף אחד, שהוא רלוונטי למקרה הספציפי הזה, אבל כמובן חשוב לציין שהמערכת למעשה כל כך עשירה בפרמטרים, שאנחנו נשתף עם כל מי שיהיה מעוניין את כל פרמטרים שכלולים במערכת, ולמעשה לתת להם ויז'ן הרבה יותר רחב, מה זה פודוסמארט ומה אפשר לעשות עם זה ומה הם הפרמטרים. כמובן אי אפשר להציג הכל בקליניקל קייס שהוא ספציפי, כמו שאייבינד הציג. אז זה ככה לסיום, ואני שמח שעשינו את הוובינר הראשון לשוק הישראלי. זה הראשון, זה בטח לא האחרון.
כן, תודה רבה לך אוסקר, ותודה
תענית כולה שלי. So I switch to English. We are actually done with this webinar. Eivind, again, thank you so much. And
I just have a comment. I think there is a few questions that we haven't answered, or I don't know.
Just 1 second. So because we are really out of time, so maybe
Okay.
1-2 other questions, Eivind, shortly.
I thought it was on the question.
To suggest that we will actually take all these questions and we will answer through Dorit. Okay, Dorit?
Yes, because
Okay.
I see some of them are product specific.
Okay.
And I was just wondering, Elena Yolovska, she asked if the specialist can see the problem without doing a gait analysis. Yes, we can also, as I mentioned, we could probably have worked it out without having a gait analysis, but where is the border between a gait analysis and the clinical evaluation is difficult. But of course, we can work with our clinical practice, but these tools are really helping us. And I think the other ones are more to the product as such.
Okay.
They are mentioned in the question, not in the chat, but in the questions.
Then now I am so let's answer some of them.
Yeah, as Elena also asks if PodoSmart can do analysis with custom orthotics above the digital insoles. I haven't tried, but it could be nice. I think I'm not the right one to answer.
Yeah, I think this is more related to podologs, this kind of question. Elena, I will answer to you in private.
Yeah. And Ramsey, I fully agree with you that it could be really nice to measure impact forces also at gait. But I think again it's a hardware question. I think that was it for the question.
Okay, thank you very much. I wish to everyone to have a great evening and see you in the next webinar. Thank you.
Yes.
Thank you.
Take care.
Bye.
Bye. Bye.